Public comments?
And nobody
one?
signed up, Madam Chair?
Okay.
Do we have-
Presentation?
Do we have someone taking minutes? I don't see Andrea.
Oh, yeah. Madam Chair, we wanted to, and want to thank Mr. Hernandez, Commission Member Jesse Hernandez, for wanting, you all wanted to get additional information on treatment for addiction. You all went through some naloxone training, many of you. And now we wanted to bring you up to date on one of the treatments, Vivitrol in particular, and we have Michael Peluso, they're going to introduce themselves, and Laurie Bush with one of the company that makes it, and they have the presentation. And I think as we move forward, especially with the detox and additional services to treat addiction, you know, we need to be informed. And so we do have also, if you don't mind, if we can just go around the table and introduce ourselves before we get over to the, and Jesse, I don't know if you want to say something?
Well, I appreciate y'all being here. I know it's our second meeting of the month, but I thought this was really important that you all get an understanding of Vivitrol and how it can be effective for the population that we have in Laredo, especially the Opiate Act and the alcohol the clients with alcohol use disorder. I think that it's important for us to look at it as part of our medical protocol for detox. And today we had a very productive meeting earlier today with Mike and Dr. Gonzalez in the mayor's office on how to do a re-entry program using Vivitrol, any type of medication assisted treatment. But the way I'm going to write the grant is using Vivitrol, probably using Pillar to try to do the counseling. But to get those people that are in jail, you know how we detox all these people in jail, and we don't want to do that. And so we want to be able to give them a shot to be successful with Vivitrol. And so we talk about that. The other reason, of course, is today so that they can talk about the efficacy of Vivitrol in, not only in our community or in our treatment programs, but also, in our detox especially. So I look forward to it. I know there's Marita, you and I have worked with Vivitrol for 10 years. We've worked with Occipital for 10 years, so we probably know a lot about it. I do want to take the opportunity to introduce Dr. Eric Avery. He's a retired psychiatrist who is interested in the opiate addiction. He lives in San Ignacio, so he's interested in the opiate addiction crisis, and he's here because he wants to be able to understand. And he's actually an artist by trade now, a painter, and I invited him here. And so, at any rate, why don't we go around the room and everybody can introduce themselves.
Please. Well, let's start on your side, right there.
Okay. My name is Erica Lopez, and I'm here from Border Region Behavioral Health Center.
Thank you.
Yeah, hi, everybody. I'm here with Gateway Community Health Center. We're in the Health Education Department.
Jasmine Vidal from Gateway Community Health Center from the Health Education Department.
Manuel Maciel, Assistant Chief with Laredo Police Department.
Luis Serna, Chief of Health Preventive Services, here Laredo Health Department.
Hector Gonzalez, Director of the Health Department.
Elsa Indigi, Chair, Co-Chair.
Estela Quintanilla, Chair.
Steve Gutierrez, member. I was appointed by Councilmember Rudy Gonzalez.
Margarita Garza, member. I was appointed by the Webb County Commissioner, Precinct 4, Cindy Liendo.
Fernando Navarro, I'm in LPC with the Health Department.
Genesis Cardenas, I'm in LPC and LCDC here for the Health Department.
Marco Villas, and I'm also in LPC and LCDC here with the Health Department.
I'm in Guerrero, LPC intern, LCDC, part of the Health Department.
Marina Morales, Mike's Purpose, Overdose Awareness.
Eric Avery, I'm Jesse's new friend. I'm an artist psychiatrist and I live in San Ignacio, and I've made art related to opiates. So I'm here to
And I'm Michael Peluso. I'm a key account manager at our Health Systems Division for Alkermes, and I'm just so happy to spend some time with you tonight and looking forward to starting a conversation.
And I'm Lori Bush. I'm out of Austin, and I'm your local contact. So it's quite cool. Thanks for having us. And if you haven't gotten some dinner, please help yourself. And then I'll pass out these little booklets when we're done presenting, and everybody can have one as well as our cards. So if you have any other questions, I can get back and follow up clinical education and work to come into the group from, that's my arena, is how I can do that.
So should we get started?
Mike?
So, good evening, everyone. I want to say thank you again for your time because I understand this was a special meeting. So thank you to Jesse, Dr. Gonzalez, and to the committee for coming out. This is an important conversation for the community, and we're happy to facilitate that conversation. One of the things that I think is so encouraging for me as an individual who lost his brother to an opioid overdose is to see the community come together and really say together, let's focus on tackling this issue. So tonight, we're going to talk about a lot of key things. Jesse mentioned the product, so I am going to speak about the safety and the efficacy of the product, and if we have time, really dive deeply into the clinical outcomes data for those that's really interested in it. But I really want to talk about things globally in terms of the community and how we can together create a better system to really help open access to the citizens of Laredo and Webb County to have more access to treatment, to be able to get screened and evaluated, and to be placed in the right level of wraparound services and even on the right medication to help support their decision to recover, to help protect their decision to be abstinent. Recently, I had the honor, and you can tell that I'm from Northeast Texas by the way I talk. Right? I'm just kidding. How many Astro fans are in the audience? Is everybody an Astro fan?
Of course.
Okay. Well, then I won't tell you that I'm a Yankee fan.
Okay.
So I'm from New York. We'll get this out of the way. I'm from New York. I moved to Dallas, Texas, so I come to you from Dallas via New York, and I'm so happy to be here. We had a great conversation today, earlier in the day. But late last month, at the end of September, I had the honor of speaking at Unlocking Doors, which is Unlocking Doors sponsors the Texas Reentry Symposium. So all the heavy hitters from TDCJ, the local treatment community in the Dallas-Fort Worth area come out, and they have a lot of presentations and a lot of talk around it. Sheriff Brown from Dallas County, Chief Hall, and a lot has been happening at Dallas and Fort Worth. They've been in the news a lot, right?
Yeah.
So one of the things that I'll pass along to you is so you can get an idea of kind of who I am and my background. I just celebrated my 10-year anniversary with Alchemist. And I'm happy to say it's one of the proudest decisions I've ever made because this company, and we'll talk a little bit about it, is really our hallmark is to really meet unmet needs in the medical community. But one of the things that we tackled early on is alcohol and opioid dependence. And we make long-acting injectable biologics that support people in recovery in the central nervous system area for both schizophrenia as well as for alcohol and opioid use disorder. We're a growing biotech company, but in 2013, I started a conversation in the Hudson Valley of New York with one of the counties, a small county in the Hudson Valley called Dutchess County, about having a reentry program. Well, it took them about 3 years to actually do it. The first county that came on board was Orange County in 2015. And I'll share with you why they did that. They saw a tremendous growth in their correctional population. And then they saw a tremendous growth of people going out into probation, and they were just overwhelmed in the community. And the majority of those people, they had learned that they had become the addiction and the mental health treatment facility for the county. And so the sheriff is here, supporting this. And so what happened was they were the first county in New York State in 2015 to put a reentry program and open up access to Vivitrol specifically with comprehensive treatment and in partnership with community stakeholders. So that started the first conversation. And when I left in August to transition down to Texas and Oklahoma, at that point in time, we had 43 reentry programs. 4 of them were in the State Department of Corrections, focused on parole diversion population. These were parole violators that were, they violated parole, but what happened is they learned that they had a substance use disorder. So they would send them to a specific state facility, and those folks would have access to MAT and comprehensive treatment, and then be discharged with an appointment at a treatment provider. And there were 39 county reentry programs. So 39 programs with the sheriff's departments, 4 programs with the state of New York. And in all of them, what I learned is we've got to pull the community together. We've got to gather our resources and the folks in the community. And that's where we're going to have the best way of opening up more access to help more people. So I'm going to pass this along if you're interested in you know, I don't want to really talk about myself, but if you're interested in learning a little bit more about who I am, it's inside of there. So if you look at this presentation here, I think I'm a big statistics guy, right? And I don't know, this presentation talks about Vivitrol in the context of the criminal justice system, but I do want to make a comment before we get into the presentation that somebody doesn't have to go into the criminal justice system to have access to this medication. If I can deliver any message to you, we would prefer that they avoid that altogether, and that we open up access to help them to divert the ability of having to go to jail, because we know the stigma that's tied to that, and we know unfortunately what that does to an individual for the rest of their life. So I think it's important to put that into context. And I don't know the local statistics, although Dr. Gonzalez, I think you shared with me, what was the number, 43 overdose deaths?
In 2017, we had 43 overdose, 35 of those were opioid. In 2018, we had 32. 28 were opioid. And for our community, that's a big disparity.
Yeah, a community of 75,000 people.
175, yeah.
175,000, I'm sorry. So that is statistically, that's a large number. Does anybody have an idea? So one thing I'll share with you, overdose, we know we're in the midst of an epidemic. Everybody knows that, that's why we're here tonight, right? To try to find some solutions to that. In 2015, if you look at this map here on the top of the United States, if there's red, that shows where the most overdoses. And you can see in 2015, if you look at this map, and I'll pass this around and leave this for you, there's only a couple of red hot spots in the country where they're reporting and seeing this amazing overdose rate, right? And actually, this is data from 1999, but by the time it gets to 2015, you see the color all across the country is changing, right? If we were to show you data from 2017 and then 2018, what you're going to see is the entire country is red. So there's a lot inside of that, right? The epidemic rages. Unfortunately, fentanyl is mixed in, you know, and it's become more potent and powerful, right? But there's other components to this. The reporting from the Department of Health or from the coroner and all that has changed too, whereas we're doing a better job of tracking all of those things. But the problem is, too many of our citizens, too many people are dying as a result of that.
Mike, and I shared with you the overdose, but Chief Maciel, if you want to share the response calls that our law enforcement, just on the police side, had to do.
And it's not only, you know, it tracks deaths, but the response to actual overdoses is daily. Daily.
What would you say your average number of calls? I'm just curious.
I would say it's probably like two a day.
2 a day. So on average, about 60 people, 60 calls a month.
And those are the ones that, you know, and then that's the other issue, you know, sometimes they're classified as a medical type of call, and we're not grasping the correct picture that it's an actual overdose. So those are other gaps across the nation that are probably not being reported.
So that's one type of gap, right? The ability to respond. There's another gap, there's treatment gaps, right? And then if we put it in the context of people transitioning out of a correctional facility or a detention facility or a jail or a prison and then having access to treatment, there's even another gap. We'll talk about why all this is important, but does anybody have an idea of what the economic impact of opioid misuse is in the United States? And by the way, this number is from 2013, so take a guess. I've only been in one audience where somebody actually guessed right, and it was a total guess, but they were pretty much right on it. Take a guess, just pick a number.
A cost?
The total cost of opioid misuse in the United States. In
500 million?
500 million, okay? Anybody else want to take a guess? Come on. Just throw a number out.
6 billion.
6 billion? Even better, this guy probably read my stuff. One other, do we have any other takers? $78.5 billion.
Wow.
So by the way, everyone says the same thing, wow. $78 billion is the cost to the United States, the burden on the US economic system. And by the way, that pales in comparison to alcohol.
Exactly. I was about to say that alcohol use disorders cause more damage to society economically, family, and death than all the other substances combined. So if you think about opiate in the, $9 billion mark, can you imagine all the damage that we have to society economically and otherwise with alcohol use disorders? And this is why Vivitrol is so important, because you tackle two different substances. You know, it works as an opiate antagonist. It blocks the opiate receptor, but it also blocks the dopamine receptors from having the euphoria from drinking alcohol.
Taken away from my presentation.
Well, sorry.
So I had a very... Go ahead, Jesse. Go. So anyway, I had a really good professor in school. He'd give us the answers first and then give us the test. So I'm giving you the answers first, and then we're going to go take the test, just in case anybody has to leave early, right? I like kind of summarizing it, and then we'll get into kind of expanding it out, right? So the number for alcohol use disorder is $249 billion. It's amazing. It's amazing. So opening up access for people to treat, right, is so important. Now, Jesse stole some of my thunder, but we're going to get more into the detail of how the medication works and how this is a brain disease. But I want to talk to you about, and we'll show you data that's really current from 2017 data. Comparing head-to-head to Suboxone so you guys can see, you know, its safety and effectiveness to that. And by the way, we're not anti-buprenorphine, we're not anti-methadone, we're pro-medication-assisted therapy, we're pro-people having access to every tool in the toolbox. One of the comments I said to Dr. Gonzalez this afternoon is, if I went to my cardiologist and they said, you know, there's only one blood pressure medicine we're going to use, I'd probably go to another cardiologist. So I think we owe it to the citizens of Laredo and Webb County to have all tools available in the toolbox. I think that's morally the right thing to do. Well, I'll let you guys decide. I'll let you decide that. So this is data from 2014 from the US government to the writing a report to the adult treatment drug courts in the United States. And they talk a lot about all the medications inside of it. We only have 2 paragraphs on Vivitrol, but it's very powerful, and I'll pass this along so you can see it. One of the things they talked about is studies have found that the injectable form of naltrexone or Vivitrol can improve patient adherence to the medication, because what you'll learn is this is a once every 4 months or 4 weeks, once every month, a once monthly dose of naltrexone, right? And why is that important to increase treatment retention? Because from the LPCs that are in the room, where you see people, what happens a lot? They leave treatment before they get enough tools in their toolbox to really live a life, right? And they say that treatment retention is particularly important because it provides clinicians with sufficient time so that to engage the patients in psychosocial therapy. And that's where they can learn to make the psychological and the social adjustments that support a life without opioids. So the whole goal of medication is it should never replace treatment. It should never replace the good work that the counselors are doing to try to engage people, to save their lives, to give them new techniques. It should support that and enhance that experience, right? And this is one of the things they found with Vivitrol from the studies. The other thing is, specific to criminal justice population, which we know is often a difficult population to treat for a lot of reasons. It says that recently, a recent multi-site study of people under legal supervision, people in probation, parole, and drug court, found that those who had completed a treatment program where they had received 6 monthly injections of Vivitrol with counseling, psychosocial therapy, found 6 months after their last dose, so a year after starting, that there were significantly fewer positive urine screens for opioids than those who did not complete treatment, who didn't receive all 6 doses. Because one of the biggest questions you're gonna have for me is how long should somebody be on this medication? So this kind of gives you a foundation for that. One size doesn't fit all. Some people may need it longer than 6 months, but at least this data supports a minimum of 6 months. 180 days, that's not a lot of time. That's not a big commitment that people would have to make. They were also less likely to be reincarcerated. This is SAMHSA, the US government saying this. I'm just reading what they wrote. So to kind of give you some, so again, answers to the test, right, ahead of time. The other question you're gonna have for me is how much does it cost and all of those things, and what is the burden on our health system? Well, Dr. Shaw recently did a study where he compared all forms of medication specific to opioid use disorder. And what they found is all the medications raise costs to the health system. But Vivitrol specifically raised it the least. You'll see buprenorphine and methadone specifically raised it about, according to the study, upwards between 40 to 50% increase to the healthcare system because of the utilization. And a part of that is the relapse, the recidivism rate, people hitting the emergency department looking for help, people having to go inpatient. With Vivitrol, what you'll see is it's a medication that's used post-withdrawal, post-detox, and it really prevents that phenomenon of people recidivating and relapsing back to opioid use disorder, as well as alcohol dependency. So as a result of that, you see less of a burden on the healthcare system. So that's the appetizer. How did I do so far? Pretty good? I'll pass these along. So we'll get into this in a little more detail. And I'm just going to kind of buzz. We talked about who we are. We're a leader in innovative medicines that address unmet needs and challenges for people living with debilitating diseases. We're a fully integrated global biopharmaceutical company. We develop products that make a meaningful difference in the way patients manage their disease. We're focused specifically on the central nervous system disorder. And if you want to get specific about that, it's schizophrenia, opioid use disorder, and alcohol use disorder right now. So we talked a lot about the burden on just overall in the United States, but in the criminal justice system specifically, what this slide says, and I'll summarize it for you, is 1/3 of all people with heroin use disorder, specific to heroin, passed through the US correction system in 2002. As a result of that, the burden on the corrections, on law enforcement, specifically corrections, of that $78.5 billion was $7.7 billion, nearly $8 billion. So it's not just costing our healthcare system money, putting our hospitals out of business, it's putting a tremendous burden on our law enforcement colleagues. And I was just up in Harris County with the Harris County Sheriff's Department, and one of the things that was remarkable to me is they said, we burned through our entire budget of Narcan. And 2019 still, what do we have, 2 or 3 months, 3 months left in the year?
Yes.
And they're looking for funds to purchase more Narcan. So I think that's a powerful statement to the effect, from a cost effect on the communities, right? If you look at alcohol use, again, a tremendous burden economically on law enforcement and the criminal justice system of $34 billion. And really the summary of this is that when somebody enters into a correctional facility or into the criminal justice system or into a hospital or rehab, it shouldn't be a stigma. Oh, again, we arrested you again. Oh my gosh, you overdosed again, or you need support again. It should be an opportunity for an intervention to happen. And that's really, at that point in time, I think is the best opportunity to present all of the options that are available, a comprehensive treatment program with medication-assisted therapy. This is not our first time at the rodeo. I can say that because I'm in Texas, right? This slide is actually incorrect. There's probably closer to 700 programs that we've done in the United States and in almost every state in the country. So a lot of times we publish this stuff, and by the time it gets up here through legal, the data's already outdated, right? So we have programs in reentry programs like we talked about in county, Department of Corrections programs, diversion programs, alternative to incarceration, and court programs, mainly drug court and diversion courts and things like that. Mental health courts as well. So this is really, I know why you came out tonight, is to understand better, and you probably already have this understanding. This will complement a lot of the education that you know. And if you like what you see up here on our slide deck, a lot of it is available from your local representative. We have flip charts, we have all kinds of patient education material that you guys can utilize to continue that conversation, because if you don't carry this message out into the community, then nothing's really gonna change, right? So how do opioids affect the brain? Because what we're talking about is, just like any chronic disease, the American Medical Association and the American Psychiatric Association now define addiction as a chronic relapsing brain disease. And I think it's important that we look at that medically, because again, it also destigmatizes addiction. So we're gonna talk, the brain is very complicated, right? And it's amazing how it's designed. Like your motor, I don't really know, but your motor skills are up here or back here or something. And why do you gotta put it there versus putting it here? Because you would think, a lot of that stuff would be up here, right? But we're gonna talk about, we're gonna really simplify the brain, right? And we're gonna talk about two different regions. The limbic region of the brain. That's our pleasure and our reward system part of our brain. You might want to think about that as the caveman brain. That's like the most basic part of our brain. It sits right on top of your spinal cord. The brain stem is right there on top of the spinal cord. And even if we lobotomized somebody and took out their prefrontal lobe, they'd still be a breathing human being that would need to eat when they're hungry, etc. So that's where our basic drives, rewards, and pleasure. Everything you need to know about me is this. I didn't tell you this. I'm 53 years old, and I have a 3-year-old son at home. So I think of this limbic system as like the baby brain, because that's the part of the brain that says, I want, right? So anyone that has children and has, raised children at the age of 3 knows that that's what they call it, the terrible 2s and the terrible 3s, right? But then there's another part of our brain, and that's the prefrontal lobe, or the cortex. Specifically, the prefrontal lobe is where we do our thinking, our decision making. That's the executive functioning of the brain. It's important that we talk about this in context of a chronic relapsing brain disease, because this is the area of the brain, the limbic area is the area of the brain that a substance, fill in the blank, when a person becomes physically dependent upon that substance, that's the area of the brain that gets taken over by that substance. And that area of the brain then begins to send signals to the prefrontal lobe and tell the prefrontal lobe how to think about situation. So LPCs and counselors and folks that in recovery used to say people with an addiction had stinking thinking, right? Well, part of that is because their limbic is controlling, their primitive part of their brain is controlling the prefrontal lobe of their brain and telling it how to think. So we call that limbic hijacking the prefrontal lobe. So it kind of makes sense. And what happens with medication is, this is the area of the brain that medication is going to play a role in, the neurochemical part of the brain. And psychosocial therapy is going to help the cognitive, executive part of the brain. So it's best when both are used in combination. So an opioid specifically, if we were to take a deeper dive into that limbic region, what we would see is that limbic region has a bunch of opioid receptors in there. And there's many different types of receptors, but opioids and alcohol have a high affinity for what's called the mu opioid receptor. You don't have to remember it specifically, but just so you know, there's other receptors that play a role, like when we eat our favorite food, that might hit another receptor in the brain. So specific to opioid dependence is the mu opioid receptor, and what happens is you have a natural pharmacy inside of your brain. For example, you're hungry, you eat, your limbic gets an endogenous opioid, hooks up to the mu opioid receptor, it releases a little bit of dopamine, right? What happens when somebody uses heroin, OxyContin, or a synthetic opioid is that that exogenous opioid comes from the pain reliever, gets onto that mu opioid receptor, and thunder and lightning happens. It's like 100 to 1,000 times more dopamine release. So that's kind of where the overstimulation of the reward system is where the euphoria and where the hook kind of comes in. I'm going backwards here, okay? So understanding different types of medicines, there's 3 approved medicines by the FDA to treat opioid dependence. So we understand the disease, kind of how it happens, right, where the hook is. If you look at agonist therapy, for example, methadone, that takes a full opioid agonist, hooks up to that same receptor, and they get an excessive release of dopamine. So you can look at it as opioid replacement therapy, right? Let's talk briefly about partial agonists, which, for example, buprenorphine. What that will do is, again, it'll hook to that same mu opioid receptor, and again, there's a release of dopamine, and there's a ceiling effect that's built into it, right? So that's kind of the idea behind it, right? There's naloxone as a part of it. In case somebody abuses it, it prevents that from happening. You look at antagonist therapy. The most well-known is naltrexone, which is the active ingredient that's inside of Vivitrol. You might have heard it in an oral therapy called Revia. And naltrexone works differently. It hooks that, well, it works in the sense that it hooks that same opioid receptor, but there's no stimulation of, excessive stimulation of dopamine. It actually blocks it. Think about it as kind of like a locking key, is a nice way of kind of explaining it, right? So if exogenous opioids want to get onto that receptor, opioids from the outside, they're blocked. But if a person's eating their favorite food, they still get reward and dopamine release from that. I'm not going to go through this because it's a very busy chart, but it kind of goes down the line here again, looking at some of the differences between antagonist and partial agonist. And one of the things that I will say about antagonist therapy specifically is that it is not a DEA scheduled medicine. And one of the key differences is that unlike agonist or partial agonist therapy, it requires detoxification up front before starting it. So that could be a good thing or a bad thing, depending on it. And all of the medications should be used in the context of psychosocial therapy.
Mike, I just want to clarify for everybody, when you're talking about antagonist therapy, you're talking about Vivitrol, naltrexone or Vivitrol.
Yeah.
I just wanted to clarify that because some of you may not understand that.
So we'll talk now specifically about Vivitrol, and that was a good segue. Thank you. So what is Vivitrol indicated for? And our indications are FDA indications. That means that there has to be clinical data behind that indication. They don't just give an indication because we ask for it. You have to have the actual outcome studies that show the medication and proves that the medication can do that. So one of the things that it's indicated for is the treatment of alcohol dependence, and we'll get into the clinical studies of how it works for the folks with alcohol dependency. People should not be actively drinking at the initial time of Vivitrol administration. It's also indicated, and it's the only one of the 3 approved medications to treat opioid dependence for the prevention of relapse to opioid dependence following an opioid detoxification. And that was based on the way the study investigators designed it, a minimum of 7 days detox. and it should be part of a comprehensive program that includes psychosocial therapy. So again, this graphic kind of just reviews what we looked at for antagonist therapy. Vivitrol is an opioid antagonist. It has its highest affinity for the mu-opioid receptor. That's the receptor that plays the key role in opioid and alcohol dependence, right? And what it does is it occupies that receptor and it blocks endogenous opioids from being able to get on to that receptor. And it markedly attenuates or completely blocks the subjective effects of exogenous opioids. So it's a medicine to be used when a person makes a decision to be abstinent, when a person is opioid free. That is the time to consider utilizing Vivitrol.
Just to put it very simply, Vivitrol blocks the urge for you to use. And so it's the substitute by blocking.
Yeah, and that's really important because I'll show you the clinical outcomes data in a minute. This is the last slide, and then I'll kind of ask if there's any questions, and then we'll get into the clinical outcome data. But just to kind of summarize, treating people with once monthly injection and counseling is really the key to success here. And Vivitrol contains an opioid antagonist that we talked about called naltrexone. Naltrexone's been around for a long time. It's a very safe and effective, well-studied medicine. But the way we formulated it is in tiny little microspheres that allows an individual to receive a once-a-month dose. And those microspheres begin to dissolve, and they extend the release of the naltrexone over a 28-day period. So in the context of somebody who's in recovery, that has a ton of social issues, that maybe has to report to a probation officer, maybe has to go to drug court, or just has to show up for counseling and go to a physician for medication, there's a lot of things going on in their mind. But one of the things that they don't have to worry about is making a decision to take that medication every single day. So built into long-acting injectables is the fact that they're automatically compliant. If anybody takes vitamins or medication oral every single day, you know there's some days when you miss it, right? And what do? You just get back, right? You take it as soon as you remember that you missed it, right? With this, you're covered, the individual's covered for the course of 28 days or 1 month, right? It is recommended that they be opioid-free at the time of administration, and that recommendation is a minimum of 7 to 10 days, but we'll speak to the physician specifically about creating, helping them to do an induction protocol. And I see did you have a question or no? Okay. So what is Vivitrol? I think by now you know it's a monthly extended release of naltrexone, specifically 380 milligrams. It's only administered by a healthcare professional. So what that means is an individual doesn't walk into a retail pharmacy and carry this around with them. They have to go to their physician's office to receive it. It has no street value anyway because it's non-narcotic, but it's nice to know that they have to report into their doctor's office or to the program that's administering it and receive the medication. That gives an excellent opportunity to.
Yes, and in case of alcohol dependence, how long does it take? I mean, for opioid, they have to be detoxed. For alcohol?
Yeah, so alcohol, again, they shouldn't be drinking at the time of administration.
So they were drunk yesterday, but today are sober, we cannot.
Yeah. So again, I think it really depends where that person is. There are some alcoholics or folks with alcohol dependency that may need to be detoxed for safety purposes. But the short answer to your question is in the clinical outcome studies, which we'll get into in a minute, of 624 alcohol-dependent people, the majority of people drank up and until their first dose of Vivitrol, and it was very safe and effective, and they had great outcomes. For the group that decided, that really wanted to be abstinent, and was 7 days abstinent prior to starting treatment, they did even better. So that makes sense to me. I mean, I'm not a counselor, but it makes sense to me that why would people that were abstinent in alcohol studies do better than people that drank up into it? And I think It's just sheer motivation. The person that's more motivated and wants to be alcohol-free and abstinent is gonna always do better than the person who's saying, well, maybe I'll try it and see if it helps me, right? But it helped everybody in the study. It just helped the people that were abstinent even more. The effect was
And for
profound.
the people who was placed on Vivitrol after violation of parole or for drug court, do they have the chance to opt out for Vivitrol treatment? Or
Yeah,
they were-
all of the, I'm glad you brought that up, because one of the things I didn't mention is all of these programs are completely voluntary.
Voluntary.
Yeah. So there's nothing that would force them to be, the only thing that I see the court system, if you will, doing is mandating that they sanction them to treatment, you know what I mean? But they cannot mandate what medication. I mean, I think we still live in the United States, so I think we still have that freedom. But I'm glad you clarified that.
I just want to add one more thing, like, for our detox program, the reason why Vivitrol might be really good for our protocol is because we're gonna get people that have to be detoxed. 12 hours after they come in, the liver will have already processed all the alcohol out. So at that point in time, they can actually get the Vivitrol. As opposed to someone that's using opiates that we may have to wait a number of days, right? But that will help them. Now, as far as in the drug court program that the county has, they come in and Marita, can you explain the drug court program a little bit? What we do and how we work with the jail?
So when there's a client that's referred over to the drug court program, a lot of the referrals come in from intake at the jail with the sheriff's office. And so what happens is if we are notified that they are under the influence and that's why they got picked up, we request that they wait in their jail cells for a minimum of 7 days. And throughout those 7 days that we're trying to get them into the drug court program, we start calling up the doctor. There's a physician that's here, local, that is aware of how Vivitrol works. We request, or the doctor requests, labs, because there are certain clients that may not be as receptive to the Vivitrol depending on their certain medical conditions. And so when the laboratory results come in, if everything seems well, then the doctor will go ahead and prescribe the Vivitrol, they'll order it, and then it gets administered. Once it gets administered, then we start the therapy sessions, because we understand that in order to get treated, you have to have both in conjunction with, so.
I think, and the other thing that I want to point out is that at all points in time, the counselors that are working the program, they're always using motivational enhancement therapy to get them, to educate them and give them that opportunity to empower them to make the decision about using Vivitrol, because it's all voluntary.
Right.
They have to decide whether or not they want to use it. And so that's a goal of the initial counseling.
Where are they getting that first dose?
With Dr. Arturo Garza Góngora?
Yes.
He's the medical officer.
So they're not getting it at the correctional facility?
No.
So
The
is
correctional facility will sometimes do the court the favor of transporting the individual while they're still in the custody of the sheriff's office to their doctor's appointment and to get the labs and then to administer the test, or the medication. And so once the medication has been administered, then they'll come back to the court and then we'll release and they'll start drug court.
So I'm not putting you on the spot, have you ever lost folks that you spent a lot of time with, they said yes to the dress, but for whatever reason, the sheriff couldn't transport them to the doctor's office that day, and they just never showed up? Has that
Yes.
ever happened?
Mm-hmm.
How often would you say that happens? I'm just curious.
Not that often, because there's a lot that goes into it. I know that when I was working for the drug court program, you have to educate them as well about what Vivitrol is about, what it does, how long it's for, or what the recommended time is, the time frame. And I know that we would do it for 12 months minimum. And so, how Jesse mentions, it is voluntary. It's not something that you can force your clients to do, because they too have to be receptive to the medical treatment, and that is the office visits on a monthly basis, making sure that those lab tests are still coming out normal, and then making sure that they want to stay clean too. So no, it's not easy. It's not easy. Sometimes we do lose clients,
The only reason
but
why
it's not common.
Yeah, no, this is, everything you articulated is wonderful. It's a great protocol and program. I would make some tweaks to it on the medical piece, but that would be a conversation we probably have to have with the doctor. But the one thing, the reason why I ask you that is, would it be a difference if they were able to get on a dose prior to leaving the facility? That's the only reason why I ask. Would that make a difference in not necessarily the amount of people that would take the program, but in the ability for capturing those one or two people who kind of fall through the cracks?
Oh yeah, definitely.
Yeah, that was the reason.
It makes a difference.
I have a question on the medical. Many people have hepatitis and can't take Vivitrol. Is that still hold? I mean, if they're already taking heroin?
So, let's talk about that. I'm so glad that you brought it up. Hepatitis C, or any form of hepatitis, is not a contraindication to use Vivitrol. In fact, in the clinical outcome studies, which hopefully we'll get to some of them before you leave tonight, in one particular study of 250 people, 9 out of 10 people in that study had hepatitis C. And the reason for that was their average opioid dependence in that study from a demographic standpoint was 10 years. So anybody who's been using opioids for a chronic period of time is probably not using synthetic opioids. And in fact, we found in this particular study, the folks that entered in voluntarily to the study after 10 years of opioid dependence were using heroin, IV heroin specifically. And so IV heroin, as the doctor can explain to you, or any kind of needle sharing or what have you, leads to a tremendous amount of infectious disease. Infectious disease leads to hepatitis, things like hepatitis C. So what I'm basically saying, I said all that to say, in that clinical outcome study, 90% of the people at Hep C, they were treated safely and effectively with Vivitrol with no problem.
So would you say then that?
Denied, right?
So if-
Yes.
so
So
that's
would you
why-
say that
that's
maybe
why-
it's at the discretion of the physician to prescribe the medication?
No,
I would
think
say-
the issue is there's new data.
Okay.
There's been a lot of confusion with the medical community that if you have hepatitis, you can't use Vivitrol. But there's new data that shows no. Part of the training, we had this discussion with the doctors, is that the doctors need to understand it's a different way. What's more important, treating the overdose or treating the potential hepatic liver disease that you may or may not have?
Well,
even if you do have hepatitis C or cirrhosis, if the liver is stable, then again, the more important thing is to treat the addiction.
Cost benefit.
Yeah.
Very, very well said. In fact, in a more recent study of 2017, the National Institute of Antagonists did a study of 570 opioid-dependent people, an average of 13 years of opioid dependence. So they were even more chronic than the first group that we talked about, a much larger sample of those people. And that was a head-to-head study that they did non-inferiority of 2 medications, one being extended-release naltrexone, or Vivitrol, the other one being buprenorphine naloxone, or what you would commonly call Suboxone. And in those studies, the study investigators used a very high cutoff on the liver function test, and they didn't deny people that had active Hep C. They only denied people with really high liver functions. They were, out of the protocol, were excluded from it. And so it's exactly what Dr. Gonzalez is saying. The reasoning behind it is that what are we trying to do here? Are we trying to prevent people from relapsing and overdosing? Or are we, you know, what's more important in the case of these particular population?
I just want to point out one thing, as we were talking about what we were doing with the jail and drug court and what we could potentially do here in the detox. I want you to look at the slide that says HCP administered, healthcare professional administered. Dr. Gonzalez, am I not correct that if a doctor who writes a medical protocol puts Vivitrol in there as part of the protocol, a registered nurse, whoever the director of nursing, can make sure that that shot is administered. So you don't have to have Dr. Garza Góngora all the time, you know, at the jail, as long as he approves a medical protocol.
Mm-hmm.
And so that's a tweak that we could make in the reentry program that we're talking about. That's what we need.
Mm-hmm. I think so. I mean, if you read my biography, I've done this over 40 times, and I would say one of the things that when people started their programs, they were very conservative because they had no experience with this, and of course, you know, people are afraid of liability. But now as we fast forward to 2019, there's a lot more experience with this particular medication, but then there's the clinical data, like the data I just quoted to you, where, I mean, let's look at if extended release naltrexone was causing or accentuating the phenomenon of hep C or liver problems, the FDA would put that in our label. They do have a warning in our label that naltrexone at higher doses can cause hepatotoxicity, but there's no contraindication. And remember, Vivitrol is always administered in the same exact dose, so it's not, and it's HCP administered, so that they cannot administer more than one dose at a time. So the levels in their bloodstream are very consistent and very constant. And there's a couple of other bullet points up here. So you know that this is an opioid antagonist, and you know what an opioid antagonist means, right? We gave you the answers to the test. It's non-addictive, non-narcotic. It's not associated with diversion. This is very important. This is going to be very important to law enforcement, to the probation department, to the sheriff's department, because they don't want to use a medication that could potentially be contraband and then be diverted from inside of their facilities, right? It does require a person to be detoxed. That's important, because what that tells you, again, it's another part of an individual's, it's a part of the disease of the opioid or the alcohol dependency. There's a physical part, there's a neurochemical part, and there may be mental health and psychological parts to it as well, right? But a person actually has to detox before starting this medication. And I think what that says is it's an indication of how motivated the individual is, right? So I think that's important. And it should be part of a comprehensive treatment program that requires psychosocial therapy. It doesn't have to be, but all of the outcomes data, all the data that we're going to quote includes psychosocial. But remember, if we're talking about a chronic relapsing brain disease, we got to treat the baby brain, and we got to treat the executive functioning. If we do that together, we get a better outcome. That's what data says in all medications, right? In all forms of therapy.
I'm sorry that there's an organization here, AMA, who runs our methadone program, is not here because they've got about 200 persons that they treat, but it's a revolving door because folks are in and out of the methadone treatment. That maybe using Vivitrol might be, again, everybody with an addiction has their specific treatment, but certainly Vivitrol might be an alternative for those that are revolving around. They have the capacity for 200, but they have a waiting list of another 100. But that's the only program, the only methadone program we have here in Laredo.
So having another treatment option allows, maybe it's not going to be for the person who's appropriate. It's not going to be for the person who's appropriate for methadone or buprenorphine or Occipital, but it's going to open up option for people that want to be abstinent, have done the hard work of becoming abstinent, and giving them the option to protect that decision.
Unfortunately, the only treatment option that we have for medication-assisted treatment is for someone to go into the drug court program or the veterans court program.
Yeah.
So when I have private clients that need something like Vivitrol, I have to send them to San Antonio, where our doctors are educated.
Right.
So I do have an assignment for everybody. Everybody has a doctor. Get one of Lori's little booklets. Take them to your doctor and tell them, please read about this. We need Vivitrol in our community for alcohol use disorder and opiate use disorders because we need to educate our doctors.
I would say one step further. Have them invite Lori to come and have a conversation.
And that's what I was going to say. I remember back in 2013 or 2012, I'm not exactly sure, there was a presentation at the university here, and we invited physicians to come and take a look at what Vivitrol was about. And out of all the physicians that are here local, we only had a handful. From those handful of physicians, we only had one that was receptive to learning more about Vivitrol and wanting to help us out.
That was 6-7 years ago.
Yeah.
And obviously the time is coming, and you're all here, so I mean, I can't say thank you enough, but I think, the time is now.
And even mid-levels, you know,
Yes.
nurse practitioners, PAs, they can get Vivitrol, they can order it, because it's not controlled. So they can write the order, they can fill the order, and they can administer the.
Well, the health department just recently submitted to the state for certification, but because we have a Class D pharmacy and we have LPCs and clinicians, you don't need a special certification.
No.
We just wrote the protocol of where it's gonna be stored, who's gonna administer it and have it, so we're just trying to find out how we can buy it, because the cost is another
Oh,
issue.
It's expensive.
correct
Oh,
me if
yeah.
I'm wrong, you now can use Medicaid to purchase Vivitrol.
Yes,
And so
Texas
this is
Medicaid.
especially for the females that are in the drug court program, any females that you have, a lot of the females have Medicaid, so now you can use Medicaid to purchase Vivitrol.
Yeah.
So that's what's changed in that period of time. To your point, it's not, you know, a lot has changed. Number one, it's covered under Medicaid, and there's a ton of funding that's available that you guys can get access to, the local sheriff's departments can get access to, the court system can get access to. And the whole goal is to make treatment and, you know, more accessible so more people can get access to the medication.
I know that one of the issues that some of the clients at drug court had when they sought out medical coverage, specifically Medicaid, they had trouble obtaining the coverage or the medical coverage on this insurance because they were drug addicts.
Yeah.
And so, unfortunately, when that happens, then they're not eligible for Medicaid, so they're not eligible for the medication or any other type of medically assisted treatment.
But if they do have Medicaid, for whatever reason, if they're SSI or they happen to have it, you know, and they're not pregnant, it's a good choice.
But I really think this is where the counselors need to advocate, because what have we learned? All of the people that we work with, especially the women that are heroin addicts, even the men, they've all been traumatized. They probably all have PTSD. All the women we deal with
Right.
that are heroin addicts have PTSD.
Right.
So what you do is you advocate for them and make sure that the top diagnosis is PTSD,
Right.
post-traumatic stress disorder, and everything flows from there, including their addiction. And if you have to advocate for them, you advocate for them, because that's what they need.
Right.
You know, why would they be denied some type of insurance just because they were sexually abused when they were younger? That doesn't make sense.
Right, right.
Yeah.
So what is the cost?
$1,007 for uninsured, uninsured.
Per dose?
Per dose.
Per dose.
A month.
Yep.
You do have
That's
private
not-
insurances that have some
Private
coverage,
insurance
right?
covers-
All of them, about
Yeah.
95%, almost every private insurance.
Yep, all
And
private
Texas
insurance.
Medicaid, all managed Medicaid, T-TOR funding, if that's available, which I know
That's-
some like Tropical was recently. And then the new funding that we have for the
Yeah.
CJ.
And by the way, that quote of the cost is the uninsured pricing cost, right? But that's not the cost that gets charged to Texas Medicaid. That's very important. They, you know, all types of government pricing is the lowest by law, by federal law, and state law has to be at the lowest possible price.
And
And the VA covers it, the VA uses it a
It's
lot.
on
That's
formulary.
important.
Yeah.
What do you all talk about?
That's based on contracts, everybody's contracts are different. I don't know that, I'm not in our trade.
And it usually goes through their specialty pharmacy, so what will happen if you had like a Blue Cross client or United, there's an enrollment form that I can provide for you, and it's a 3-page form that you just fill out, submit a copy of the insurance card, and then the hub will then determine what specialty pharmacy it follows through, and then they ship it to the clinic.
Yeah,
And then
but
they give a shot.
The cost, I'm not gonna say is irrelevant, but it's covered by the insurance companies.
And it's under the medical benefit, so out of pocket to the client is usually really not very much at all, unless it's a January effect and they haven't had a deductible met. Yes, sir.
We also offer copay assistance and there's a patient assistance program as well.
I also remember we had a couple of clients that were private insured, and so their first month was free, quote unquote, and then with that form that they would have to submit from the doctor to Alkermes or back and forth, then that's when the copay or the partial pay began for their treatment. But I do remember there was one actually. He was Blue Cross Blue Shield. His first month he didn't have to pay for his dose.
And that could very well be because of, and depending on the timing of the year. And that can happen a lot of times where there's no out-of-pocket cost, because if they've met their deductible, it's on the medical benefit, so it could very well be zero.
Okay.
You know, especially if they've had treatment or they've been in and out of medical care for the calendar year, it very well could be zero out.
So then I guess it would, we could say that it depends on whoever's treating the patient. They would have to, call the insurance and check benefits and all of that.
So that can be
Okay.
taken off of y'all. That's, as a provider, they simply fill out the form, send it in, and we, on our end, can help navigate all that mess. Because each insurance is gonna be different, except for Texas Medicaid will go through a retail pharmacy. So if you have a client that actually has Texas Medicaid, I can help you just figure out which pharmacy locally ought to be able to ship that.
A couple of other things that have changed since in the last 6 years is we have field reimbursement managers that will work with offices, work with programs. We have a Vivitrol Now program that makes it readily available, where doses can be available right in the office. And then the office can bill directly to the insurance company, so there's an option for that. They also can help with the benefit verification and make sure that the office or the physician knows what pharmacy to get the medication to, so that's what Lori's referring to. So there's help with that. The other thing that we have now that we didn't have before is clinical nurse educators, so actual RNs that will go out and train physicians, their nurses, nurse practitioners, PAs, on how to properly administer it. This is an injection once a month. It's not an oral medicine once a month. It's an injection that the person receives at the physician's office.
So Michael, your medication is in these little microspheres.
Yes.
And so that's why it's so expensive, is you all have, your company has a patent on that. So one question is, when does that go off patent?
I don't know.
And my second question is that this medication that's not in those spheres, is it available in another formulation?
Yeah, so
it can be used on a daily basis.
Yes.
It's much cheaper.
Yes, it is not as cheap as you would think, and it's not as efficacious, and it has not proven in clinical studies like the extended release to do
I understand the
prevention.
value of one shot.
But it's all about what the medication's able to do. So oral naltrexone, or Revia, has been available since early 1985. I was a freshman in college in 1985, I remember that. So it's been available for a long time. And if it was able to prevent relapse opioid dependence, I think we probably wouldn't be here right now. So it doesn't have the same indications. It's really indicated to treat alcohol dependency. And the biggest challenge with it, doctor, is the fact that I think, and Jesse can probably, the folks in the room can testify to this, is getting people to take it.
So
And then leave it on the table.
anecdotally, what would happen is when, let's say Dr. Rodriguez tries naltrexone, we had to make sure it was a good match, they had a family support. Because if you give it to a client that's an addict, they may take a dose and follow it for a while, but then when they want to take a relapse, they're gonna not do it. So we had to find a family member that was willing to provide that medication so they could have it. And so you had to find the right patient. So in essence, it's not as efficacious. I mean, that's what I've seen. So when I found out about Vivitrol, I said, wow, this is a winner for me and for the community, especially as we were writing the first grants from the drug court and all that. I said, this is really good for us. And if you look at, we would get grants originally. The original grant was 3 years, $975,000, right? And $25,000 a year was for Vivitrol. So that's $75,000. But we saved in that first grant that we used Vivitrol, our community over $560,000 in cost to the jail, in theft and all the stuff that goes on. When I finally did my evaluation, so that grant of $975,000, you add that $560,000, so now you have a 1.4 million grant money, that was there. It helped the community out. Just $25,000 a year. Those clients, those drug-free days that those clients had, it helped us that much. But that was all the money we had. We didn't have that much. And so now we're looking at how can we expand this. Now there's more opportunities than there were 10 years ago. And I think this is the right time for it.
Timing's everything.
And I think just use us as resources because, you know, I'm down here and I cover the whole valley. And I mean, even, we got a call yesterday from McAllen, same problem. You know, this nurse has a client she wants on Vivitrol and she's like, who gives the shot? And I was like, you do. You know, and she's like, I do? And I was like, well, yes, you know, you're the nurse, you're the healthcare provider. And she was even a nurse practitioner. But she was like, I called and there's no one in town. I said, then you need to step up, it's your client.
I do want to say something about Occipital because, you know, when you're looking at the price, a lot of people don't know that we got many free doses for people that were in jail, right, Margarita? From Occipital.
The first one. Mm-hmm.
The first dose for free. And so, you know, Occipital, yes, they're, but they understand, you know, that this works, and so.
And there's
I
also a
appreciate it.
patient assistance
Exactly,
program,
yes.
and, you know, they do need to qualify, but if you have a client that needs Vivitrol and they're indigent and they, you know, will complete the form, they can qualify for doses through the PAP program. It's not a traditional PAP program, but it is available for those that
And the
qualify.
federal government has made funding available, state opioid
Yeah.
response grants, state treatment response grants, millions and millions of dollars. Texas has opened up through T-Tour, millions of dollars available to help treat opioid dependence. There's a ton of funding. SAMHSA also has funding available. So you're gonna see in the governor's office also is making more funding available for MAT. So I think there's plenty of funding to go around to support treatment and to support the ability for you guys to access medication. And again, look, it's your community's decision as to what you do. I mean, we didn't even get into the data. I don't know if we have time to. If you'd like to, we can do that.
Like, you can kind of, because some of the members have to leave, because I think you summarizing is gonna be critical.
Yeah, I think the summary of the clinical outcomes studies, I think we talked about it. You know, two
Just
key.
side effects from it.
Yeah.
Are there side effects?
Of course,
that
every
make people
medication
not-
has side effects. So in the clinical outcome studies, the number one, this is a deep intramuscular injection, so the number one side effect that's seen are injection site reactions.
And I think that's the most common.
Yeah, that is.
What
the
about
most-
sex life, libido?
So that is not.
Pleasure.
That's,
Orgasm, that.
yep, there's no, that's the most important thing, right? I'm joking. It's not about overdosing or dying. But I'm so glad you brought that up. So if you remember our pleasure zone, right? And remember I talked a lot about the mu opioid receptor. Well, you're a psychiatrist by trade, correct? Okay. So you know that there's other pleasure receptors in that hedonic system. I'm not sure if I have these exactly right, kappa and delta.
System,
It's a different system,
okay,
exactly,
well,
thank you.
all right.
Yeah. So you can still enjoy your favorite Thai food, you can still enjoy exercising, you can still enjoy intimate relations. Yeah, those things are not.
Because these are questions that are asked.
Does Vivitrol
I'm embarrassed.
increase suicide rates or tendencies or?
Yeah, so in the clinical study, in our package insert, I think there's, it's noted that there was one reported case of suicide of an individual being on Vivitrol, and I don't have the package insert in front of me. But I believe that what they found was they were unable to say it was directly related to.
But to that too, Mike, because some of the overdoses were classified as suicide overdose, and so, again, making the decision, treat so you don't overdose or commit suicide. And so that's the issue also that clinicians are having to make, because some of the overdoses were suicide. So we can prevent the overdose by treating, then we can prevent suicide too.
And I think also remembering what is most important is that it's never just given a shot and walk down the street and don't have relationships with your counseling, work in your program, doing whatever it is you do to work active recovery, that never goes away. And so that way, if you are getting feelings of sadness or something, you're talking, you're in community, you're not isolating, whereas, because it can sometimes take our brains up to a year to reprogram for addiction. You know, when suddenly we're off a substance, resetting that brain back to what it was baseline prior, and those pleasures and everything exactly where our baseline was, can be up to a year. So it's real important that you stay with your counseling and your, you know, your meeting, community, family,
You know,
friends.
keep in mind, they have to walk into an office to receive this
Yeah,
service.
putting
So,
eyes on them.
You know, and you design, the community designs the protocol, and it's the physician's call at the end of the day. It's their discretion, as you pointed out before, to kind of make that call. So you design the protocol on this, but.
Well, we have 4 LPCs right
Yeah.
here.
You know, and in reality, I've never met anyone that had an opiate addiction didn't have a depression or mood disorder.
Right.
And so just like any other medication that you're gonna give an antidepressant, well, you know, you're not gonna commit suicide at the lowest point. But once they start getting the medication or getting better, that's when they really start thinking, okay, now I have the energy to do it. So the counselors have to watch. It's the same thing with this, but it's not because, it's because of the other stuff. It was because of the co-occurring psychiatric issues that probably led to the suicide or the parasuicide. It was not basically the Vivitrol. I mean, it may have happened on the Vivitrol, but there's other issues that we have to work at.
Right. I mean, if we go back to the disease state in its very basic form as we presented it here, this is a disease of the hedonic system, where the pleasure system is, you know, attracted to that particular substance. So it is not uncommon, and I'm so glad as a professional clinician you pointed this out, and I think the data bears this out, that you can, when you understand opioid dependence, behind this is a whole cascade of neurochemical effects that occur. One of them is the overproduction of norepinephrine. So when you remove that opioid, then there's this overstimulation of norepinephrine, right? But over time, what happens is that's your fight or flight chemical. That begins to calm down. But it also unmasks an underlying issue of chronic depression and opioid dependence, and you could probably say this is true for alcohol dependence, kind of go hand in hand. And that is because the person's so used to getting that pleasure from that opioid or that particular substance, now you remove that. But over time, that changes. What's important inside of this is, can you treat it? Just like you said about, you know, is it the Hep C that's important, or whether or not this person's at high risk, you know, do we need to get them into treatment? We can treat the Hep C, right? So you can treat depression very, very easy, you know, with counseling. You can treat it with medication. I think it's important to know that Vivitrol does not interfere, or naltrexone, the active ingredient, is not processed on the same pathway that antipsychotics or depression medications, or for that matter, diabetes medications or cardiovascular medications. So what am I saying? If a person's on cardiovascular meds, it's not going to affect the safety or efficacy of those medications. You can use Vivitrol or naltrexone safely and effectively with those medications because it's not affecting the metabolism of those other medications. So that's important to know. So you can treat those two things, you know, together.
I think you mentioned something that's really important. We need to look at this holistically and do wraparound services, have really good wraparound services. You know, the other thing is when we're working opiate addicts, we have to remember, and you know, I work with the clinicians I've supervised, we work a lot on psychopathology and personality disorders, because we see so many borderlines, and what I see in my practice aren't actual, they're parasuicide attempts. They're parasuicides. They want that attention. A lot of them are the borderlines that you see that, with the cluster B clients. And so it's important as clinicians that you all not only diagnose the clinical stuff, but the actual personality disorders, so that you can do the right type of therapeutic milieu that treats that, right? And so we've talked about that in trainings and different things, in different types of meetings we've had. But the reality is that we're dealing with people that have very complex issues. We deal with people with quadrant 4 co-occurring psychiatric substance disorders. We have people that have complex traumas, that they had traumas as children and adolescents and as adults. We have people that have complex personality disorders that have from different clusters, typically cluster B and cluster C. And so those are the clients that we've seen in all our programs, with the City of Laredo and our drug court program. That's what we see. And a lot of them come from our heroin addicts, 25% of our heroin addicts. So we do have to have the right treatment protocol, but we need to have the right medication. And so I appreciate you being here.
Thank you so much for your time. I will show you this one piece of data because I think it's important, and Dr. Gonzalez, you hit on it. So this is a double-blind placebo-controlled study of 250 folks. Average opioid dependence is 10 years, as we spoke about. And all of these people were required to abstain from opioids for a minimum of 7 days. That's the way the study investigators designed it. And then they were referred to two groups, one receiving an actual injection of 380 milligrams of extended release naltrexone, Vivitrol, the other receiving a placebo. Both groups are getting counseling. And the primary endpoint in the study is to look at higher rates of, not only higher rates of completed abstinence during the entire study, but whether or not Vivitrol was preventing people from relapsing to opioid dependence. That's the primary endpoint. And you can see that in the Vivitrol group, and it's highly statistically significant, that the folks in the Vivitrol group increased completed abstinence during the whole 6 months of the study by 50% more than the placebo group. But when they looked at folks that were, when they looked at opioid-free weeks specifically, what they saw was a significant difference. And when the FDA looked at this data, that's when they chose to provide Alkermes or Vivitrol specifically with an indication of prevention of relapse opioid dependence, because they looked at the median patient inside of that study. And what they saw is the placebo person was 35% opioid, had experienced 35% opioid-free weeks over that 6 months. But the Vivitrol person was showing confirmed abstinence with a negative urine screen of 90% during the 6 month period. That's significantly different. But there's a couple of other, this is really the data point that I wanted to talk to you about, because everyone thinks that in order to reduce cravings for opioid dependent people, you have to give them an opioid. And actually, that's not true, because Vivitrol has been shown in this study, they did, as a secondary endpoint, look at cravings specifically. And the way they looked at it is they had everybody in the study on a scale of 1 to 100 say, what's your craving level? They took all of that data and they averaged it out. And you might not be able to see this in the back of the room, but there's a dotted line here. That dotted line represents the baseline. Now, what I want you to see is that in the placebo group, where they're receiving a placebo and they're getting counseling, right? They begin to experience in the first couple of months a reduction in their self-reported cravings. But look what happens by the end of the study, by the end of 6 months, what are their craving levels at? Slightly above what it was when they entered into the study. So that says something to me. That says the work that the counselors do, the treatment providers do, does have an impact on a person's cravings. And at best, at least in the case of this group of people, it can maintain them at the same craving level, right? But when you look at the impact that Vivitrol combined with counseling did, look at the first dose. It significantly goes down. Second dose continues to go down. By the third dose, it goes down further and kind of troughs off. By the end of the study, statistically, they're saying there's a 55% difference between both study groups in terms of reported cravings. But here's what happened. The study investigators wanted to find out, by the way, that was highly statistically significant, which means it didn't happen by chance, but they wanted to find out when was it statistically significant where it was not by chance that the person's saying, I'm feeling better or I'm not craving as much, versus it actually was statistically significant. What they found is that phenomenon happened after the person received the second dose, which says if a person comes out of a rehab or a hospital or a correctional facility or just goes to your treatment center and gets one dose and says, you know what, I feel better. That makes sense because the data says that. I feel I'm not craving as much. I'm not wanting opioids as much as I did before. I'm done. No. they really need another dose before that's not happening by chance, and you can feel confident that when they say that, the chances are it lines up with the study that is statistically significant. That's why it's important to design a protocol and system that allows people to have access to multiple doses, because it's not just one dose that's gonna flip a switch in their brain. They spent a long time conditioning their brain to think a certain way, to react to neurochemically to a certain way. It's not gonna change by just one dose or 2 doses. They need multiple doses. So I wanted to show you that. And then the last piece of information is treatment retention, which is important because remember we started out with the SAMHSA piece that said it's more likely that people stay in treatment, right? If they receive 6 monthly injections. Well, this data supports that. The people in the Vivitrol arm stayed in almost for the entire study. It's a 180-day study. They stayed in treatment for 168 days versus the people just getting a placebo and just getting treatment alone. Again, all of these things are important. More time in treatment statistically leads to a better outcome, makes your life easy, because most of the folks that you're gonna lose in your treatment program and your counseling are gonna occur in the first 90 days. And what happens in the first 90 days? They relapse. There's statistically higher incidences of overdoses, and those overdoses could be fatal. So I wanted to point out that data for you. Again, I appreciate your time. If you have any questions, I mean, we'll be here to answer them for you.
Thank you.
Thank you.